Good afternoon, everyone. Welcome to today's webinar entitled Navigating Eating Disorders in Your Patients with Type 2 Diabetes. A few things to note. Participants will be muted upon entry and videos turned off. For technical assistance, please use the chat feature located at the bottom of the box. You will also receive an email approximately 1 month from today requesting feedback and impact on today's presentation. After today's presentation, we ask that you visit our training center located at www.nseedus.org/training to view other training opportunities offered by NSEED. I'll now go ahead and introduce today's speaker. Today's speaker is Dr. Rachel Good, an assistant professor at the School of Social Work at the University of North Carolina at Chapel Hill. Dr. Good received her PhD, MPH, and MSW from the University of Pittsburgh. Her research focuses on the development, implementation, and evaluation of interventions at the intersection of disordered eating and chronic health conditions. Dr. Good is also a licensed clinical social worker and has practice experience with the treatment of eating disorders among clients in university counseling centers and community-based mental health agencies. Currently, Dr. Good is the principal investigator of an American Diabetes Association grant to understand the factors related to binge eating and to improve appetite self-regulation in Black adults with type 2 diabetes. I also would like to let people know that recording of this webinar will be available within 2 weeks from today on the NC Training Center. Slides will be sent out along with our evaluation immediately following the webinar. We will have all unanswered questions sent via email within 1 week from today by Dr. Good. We will also have a Q&A segment at the end of this webinar to address any questions posed today. I will now turn things over to Dr. Rachel Good.
Thank you, Michelle. I am so grateful to be with you all today. I'm really looking forward to just sharing what we know about eating disorders and type 2 diabetes. And I am hopeful that you all will leave today with more knowledge, more confidence to be able to help our patients who are managing this intersection better. So today we are going to go through a couple of different things. One, we're going to just review the definition and types of eating disorders. We're going to explore eating disorders in the context of type 2 diabetes. We're going to examine health outcomes for patients with type 2 diabetes and eating disorders. And then we're going to end with some considerations. We're going to do a case study for working with patients who have type 2 diabetes and an eating disorder. So just to overview, anorexia nervosa, bulimia nervosa, and binge eating disorder, they are probably the most common eating disorders in the United States. However, when you look at these numbers, don't get scared, because what they represent is that we do not effectively know enough about who has eating disorders. There are a lot of stereotypes about who has most commonly has an eating disorder, and often those stereotypes, we think of adolescent white women, cisgender women, but we know that anyone can have an eating disorder and they can affect anyone. As we've been hearing more in the media about more individuals coming forward, feeling brave enough to come forward about their struggles with eating, I think it's helping to normalize that we all could be in this situation. And so, particular to what we're doing today, when we think about anorexia nervosa, right, that is an eating disorder that has more restriction, right? And patients often have an intense fear of gaining weight. With bulimia nervosa and binge eating disorder, they share commonalities in that individuals will have binge eating episodes. But the difference with bulimia nervosa is that individuals will also engage in episodes of purging, whether they use laxatives, whether it's vomiting, to get rid of the food. Excessive exercise, it can be done in a number of different ways. We also have avoidant restrictive food intake disorder, where people have an intense fear of certain food groups and they might, kind of stray away from eating certain things. And then we have this other category, which we're learning more about other things that might fall into that maybe aren't defined, but they still would consist of disordered eating behaviors. So as I show the slide, as I think about the landscape, what we know about the intersection of type 2 diabetes and eating disorders, I think what we know is we know it's present, but there's still a lot that we need to learn from those who are experiencing this, the reality of those who are navigating this. And so today, as I go through, I just want to present to you, I'm trying to do a good overview of the literature, what we know, and just to kind of help you all feel a bit more confident. And so when I think about this slide, one thing I want to highlight is this is DSM-4 diagnosis, but in those who struggle with type 2 diabetes, you see binge eating disorder is the most common, the largest, most prevalent eating disorder. Then comes bulimia nervosa and eating disorder not otherwise specified. So now that might look slightly different, but that's still tracking. I think this study was done in the late 90s, but we still see that pattern. And so when I think about, this was a graphic from the American Diabetes Association. They have a mental health workbook. And so this, I thought, presented a great visual when we think about how common are eating concerns in patients with diabetes. So when we look at type 1 diabetes, we see, now you see at the top, I just want to orient you to this. The top is eating, so DSM-5 diagnosed eating disorder, and then the bottom are disordered eating behaviors. And so that would fall everything else that wouldn't meet DSM-5 criteria. And so you see when it comes to type 2 diabetes, about 1 out of every 10 patients might have a diagnosed eating disorder, but 1 out of every 4 patients might have disordered eating behavior. So almost a quarter of all patients. And so it's actually more common than we would believe. And then if you look at type 1 diabetes, you see it's a little bit higher. And so these are the most common disordered eating behaviors with type 2 diabetes. One will be binge eating. And then compensatory weight control behaviors. As many of you probably already know, when a patient gets a type 2 diabetes diagnosis, they also receive encouragement to try to lose weight. And so because what the research has shown is that weight loss can help participants help improve glycemic control. So that is a very common recommendation, and it's something that patients are commonly, hearing a lot about when they have type 2 diabetes. Or if they have pre-diabetes, weight loss is something that is kind of ever before us. And so when patients are trying to engage in these weight control behaviors, what they may be at risk of is engaging in behaviors where they are, maybe cycling in between dieting and binge eating behaviors to try to manage the weight. And so we'll talk a little bit more about that. There's also night eating syndrome. And so this is a time where, again, this is not a DSM-5 diagnosed disorder, but this is an eating behavior. Again, when patients, just how it sounds, they might eat a large amount of calories in the evening hours. And so these all really impact glycemic control. There's also other emotional eating behaviors that are related, such as emotional eating or external or restrained eating, whether you're being prompted by external eating cues and very susceptible, which I think many are in our country, or restrained eating, where you are kind of operating from a frame of restriction, which again, that can also be challenging when people get their type 2 diabetes diagnosis. So I wanted to provide a definition of binge eating, since we're going to be referring to it quite often throughout our presentation. So binge eating is eating in a discrete period of time within any 2-hour period an amount of food that is larger than most people would eat in a similar period of time. But it also comes with this lack of control. So individuals often feel that they aren't able to stop eating, even though they would like to. So I often give the example of like a snowball. And as it's rolling down the hill, people see it rolling, but it kind of takes on a life of its own. And so sometimes that's how patients have said they felt when they are in the midst of a binge eating episode, kind of just out of control. And so if a patient is going to get a diagnosis for binge eating disorder, you see some of the criteria. So they have to have weekly binge eating episodes for, I think, about 3 months. They have to have weekly binge eating episodes. Binge eating has to be associated with 3 or more of the following: eating more rapidly than normal, eating until feeling uncomfortably full, eating large amount of foods when not feeling physically hungry, eating alone because of being embarrassed by how much one is eating, and feeling disgusted with oneself, depressed, or very guilty after overeating. Another key marker is this marked distress, right? Patients are not usually they're not happy about this. This is very upsetting to them. But there are no compensatory behaviors, right? No purging, no excessive exercise. And so you can imagine when individuals are engaging in recurrent binge eating episodes that some of the consequences might be rapid weight gain and difficulty managing the glycemic control. So what we see, there's a lot of different ideas about prevalence, but 8 to 20% of patients with type 2 diabetes might struggle with disordered eating. And so that, when I think about the graphic I showed earlier with the 1 in 10, this is just, we're trying to pull all the data pieces together. So you might say, well, you said this differently. We're trying to pull everything together to get an idea. And so, as I said, binge eating disorder is the most common eating disorder in this population. And so I wanted to go through some of the research, right? Some of the studies that have helped us learn and think about how type 2 diabetes is, how people are navigating binge eating in the context of type 2 diabetes. This was a study that was in a multi-ethnic population. They had type 2 diabetes, and it was in a sample of 140 patients. So the sample is about 37% Hispanic, 40% non-Hispanic white, and 19% Black American. And so patients were administered the questionnaire on eating and weight patterns, which is a common questionnaire often by research to assess binge eating and other eating behaviors, the binge eating scale, another binge eating measure, and the Beck Depression Inventory. And so what they noticed is that 40% of the sample had disordered eating. So again, I've given you several different numbers now of prevalence when it comes to disordered eating. And so I think what we can probably say is about 25 to 40% of patients with type 2 diabetes have disordered eating behaviors. What we noticed, though, are some demographic characteristics that were associated with this binge eating. One, patients were younger, right? They had a greater BMI, they had higher A1C values, and they had higher diastolic blood pressure values. We also noted that when patients were younger and they had African-American ethnicity, it was associated with increased odds, like 6 times the odds for disordered eating behaviors. So this was another study. This was done in Black women who were living with type 2 diabetes. And the researchers just wanted to kind of understand some of the experiences with their eating behaviors. And they were wanting to know specifically about the role of intuitive eating practices. And if you're not familiar with intuitive eating, it's when individuals are relearning and kind of learn to adhere to their signals of hunger or biological signals of hunger and fullness. There is, less restriction on what they're eating, but more just helping patients kind of be mindful and enjoy their experiences with food. And so what the women, though, when they were given semi-structured interviews, so 60 to 90-minute interviews, and they reported that they experienced lack of control around food. So that might sound like some risk for binge eating. Regular eating in the absence of hunger. They reported that fullness for them felt like sick, right? So that indicates they were probably maybe going over their body's, threshold of feeling full. And they felt stigma and shame, diabetes-related stigma and shame. And so what we know about the health risks for these patients is that each binge is just and contributes and really plays a part in insulin sensitivity. And so what we notice is that when patients have increased binge eating episodes, it is often associated with poor glucose control. However, we have seen the literature's mixed because we have seen that there may not be a huge difference between HbA1c levels between those who binge eat and those who do not. But we notice that the risk and some of the challenges might be in conjunction with age and BMI. And so one thing I think is important to think about, what came first, right? Was it the eating disorder or was it the type 2 diabetes? And so this study, I thought gave us a good example. So this was in a sample of adults with type 1 and type 2 diabetes. And so I want to show you here on the graph. So right here, this is the diagnosis of diabetes, okay? And so 1 to 5 years earlier, 6 to 10 years earlier, more than 10 years earlier. And so what we see here is with the darkest line is type 2 diabetes patients. 57% of these patients in this study reported being diagnosed with their eating disorder more than 10 years before their diagnosis of diabetes. And we see that again, when it comes to type 2 diabetes, 6 to 10 years, 1 to 5 years, but more of them were diagnosed with the eating disorder before the onset of type 2 diabetes. So that has led us to think that we're wondering if this might be the order. So individuals were engaging in binge eating behaviors, which might have led to overweight and obesity. And so then that led to their type 2 diabetes, and then might have come some of their increased challenges with impaired glycemic control. Also, what we recognize is that when you think about, I think the factors like why, right? What are we seeing in these relationships? Why are we seeing this? And so when patients get a diagnosis for type 2 diabetes, we have heard them say that they are hearing the guidance as messages about good and bad foods, right? And so participants are really maybe being oriented maybe for the first time to recognizing these foods positively impact my blood sugar, these foods do not. And so I know our clinicians aren't always telling them these are good and bad foods, but that is maybe what people are hearing and what some are receiving. And so that can lead to guilt and shame around their food choices. Okay. And so what we've seen in our science is that when people are feeling shame and guilt, then it can perceive binge eating, because what can happen is that individuals might, just like with dieting, right? Individuals are going to try to, meet the norm, meet the standard, but they are going to probably engage in maybe restrictive eating practices because there's good food and bad food. And so that creates a frame where it kind of makes you feel like you have to just kind of stay on one side. And we know the body does not operate like that. And so that can often lead to individuals have a boomerang effect, and that they can then engage in binge eating. And then people feel guilty and then they come back. Also, individuals might just distrust their bodies, right? And their cues. They are learning now that they have to think about less about maybe what they're enjoying and what foods naturally taste good to them, to those that may more positively impact their blood sugar. And so these experiences can cause patients to maybe turn off listening to themselves and maybe prioritize, kind of the outward knowledge and wisdom, which can sometimes be problematic because our bodies are play a vital role in teaming with us to help keep us healthy. And so without being able to adhere to our cues, it can make it challenging for patients to, pay attention to their signals of fullness, signals of hunger, and it might help them engage in more experiences of restrictive eating behaviors. As I also said, participants might feel pressure to lose weight, right? And so that can lead to dieting, which we have a good literature that lets us know that can also increase the risk of binge eating. So this is just an example of the binge, what we know about the binge and restriction cycle. And so usually when I show this graphic, I'm not talking about the context of type 2 diabetes, but I want you to imagine what it might be like for a patient who gets this diagnosis. So over here in the pink, right, they're going to diet and restrict. So maybe they're not dieting and restricting to lose weight, but they are now restricting because they feel like they can't eat certain foods. And so they're trying to follow the plan, right? They want to be good, maybe, ascribing some morality to their behaviors. They also might, just try to just have these actions, these physical actions, where they may not always get it right? Because we don't, as humans, we don't always get it right. And so they might find themselves in places, right, where they just can't do it anymore. And so this might lead them to have a binge eating episode. Maybe they go to a cookout and they have food there that is not quite approved on the plan, right? It does not follow exactly what they were supposed to, might be best for managing their blood sugar. And so patients often then will engage in their experiences, and they might kind of overdo it, and they might have a binge eating episode, often because, again, that restriction has been there. And so afterwards, that guilt sets in, right? People have that fear of gaining weight. Fear, it might not maybe be weight gain, but fear their blood sugar values are going to be increased. And they might test their blood sugar and see how high it is. And so then the next step, right, they will get into control. So they're going to kind of swing back on the other side, and they might engage in some more restrictive eating behaviors or try to get back on track with their, the preferred plan for managing their type 2 diabetes. And as you see, the cycle just continues. And I think as we see with the numbers, again, 25 to 40% of our patients are managing disordered eating. So this just lets us know that more than we think might be engaging in this cycle on a regular basis. So when we think about outcomes, right, what do we know about what happens when type 2 diabetes patients have disordered eating behaviors? And so what we see, again, that binge eating disorder, often it is kind of there first. And so I don't think we always think about that, but that is usually there first. And then when patients have binge eating disorder, they have higher rates of acquiring a diabetes diagnosis later in life. In fact, what we've seen is that about a third of patients with eating disorder diagnoses had developed type 2 diabetes after 16 years of ED treatment. And then we saw that in a sample of patients with binge eating disorder, about 12% of those were younger patients who had previous histories of type 2 diabetes, higher weights at BMI, and had higher depressive symptoms. We also see that it's associated with poorer quality of life. Stress can also exacerbate the relationship, I think, between glycemic control when disordered eating behaviors increase. We see that, however, when patients are engaged in treatment for these symptoms, we can have improved self-care, and it can help patients kind of understand and partner with clinicians when they are receiving help for these conditions conjointly. So now I want to talk about just some screening tools, right? So let's say you are treating patients with either type 2 diabetes, or you might be treating patients with a binge eating. And so how do we identify these behaviors in our patients? I know everyone, it does not feel, confident in their ability to identify these behaviors. And so that's why we have some good screening tools that can take the hardest part out for you. And so what we think is that in order to identify eating disorders and type 2 diabetes, what they have in common is that there's a screening, there are HbA1c, fasting glucose. And so same thing with identifying eating disorders, right? So we have brief screenings, and then our extensive screenings are longer interviews that are often used to kind of help us understand patients' eating disorder behaviors. And so the challenge, though, is that you see these numbers, fewer than 50% of persons with binge eating disorder receive treatment. Now, that should be just like, alarming, right? And I can think of a number of reasons. One, I think a lot of physicians don't really feel confident about being able to diagnose and treat binge eating disorder. Patients may not even know that it's an eating disorder. And so they may not be able to talk about these behaviors with concern or be able to let people know that they're struggling. As we see, with binge eating disorder and their limited medical recognition, less than 50% report using DSM-5 criteria to diagnose binge eating disorder. 27% do not recognize binge eating disorder as a discrete eating disorder, and then greater than 40% never assess binge eating. So along with our patients might feel guilty and judged. And so that just leads me to recognize we have more work to do, right? We have more work to do to help our patients be able to talk more freely about whatever concern they're having with their eating behaviors, and to help our primary care physicians feel confident and feel like they are able to assess and put patients in the right direction to get the help that they need. So this is the Binge Eating Disorder Screener 7. So just look, it has 7 questions. So you all should feel encouraged. 7 questions. And so as we see here, patients are able to fill this out maybe before the appointment, before the session. And so they can indicate, right, during the last 3 months, did you have any episodes of excessive overeating? And so then they can see if there's any distress present. And then they can often, use a Likert scale to, assess whether they have loss of control, if they, continue eating when they were hungry, were they embarrassed? Did they feel disgusted with themselves? And did they have any purging behaviors? Okay. And so then if the patient answers yes, right, to questions 1 or 2, question 1, then you continue to questions 2 through 7. Okay. And so if the patient answers yes to question 2, and checks one of the shaded boxes, okay? So this is not shaded, but these are shaded, okay? They check their boxes. This lets you know that, you might want to give this patient some additional support to manage their eating disorders, and they might warrant a full diagnostic screening, a DSM-5 diagnostic screening for binge eating disorder. So another is the Spoof Tool. Okay, and so you see, this is just a few questions, and they're bolded to represent scoff. So do you make yourself sick because you feel uncomfortably full? Do you worry you have lost control over how much you eat? Have you recently lost more than 1 stone, about 15 pounds in a 3-month period? F, do you believe yourself to be fat when others say you were too thin? And then the other F, would you say food dominates your life? Now, one thing I want to make you all aware of is that NC just went through a process where they developed their own screening tool that was based on the SCOFF. And so this is something that you can access right here on the website. It's free, and it will give you, very similar. Again, it was based on the SCOFF, and this is a screening tool that you can use that the center developed to help you have some more confidence and begin to screen, and it will give you advice and guidance depending on how the patient answers. So now I just wanted to spend a little bit of time helping us hear from those who actually have this experience, right? And so my team, we have been doing some research with Black adults who have type 2 diabetes, and we have been doing some interviews with them. And with some providers of diabetes self-management education. And we have been just, again, positioning ourselves to hear what it is like as they're managing this and what are some of the factors. And I think it's important, as clinicians, as those who serve this population, often, we may be doing a lot of the talking. And so we may not get the opportunity to hear as much from patients about, just some of what they're managing as they're navigating their eating behaviors. And so in this study, right now we have 14 participants. So this is hot off the presses. And so we see here our participants on average are about 57 years of age. Our participants, represent a range of education, but I'd say about 50% of our sample has at least a master's level of education, and then about 50% it's kind of interspersed between bachelor's degree or some college. And then our participants on average have been diagnosed a little over 3 years. They've been diagnosed with type 2 diabetes, and they report at least 2 out of control binge eating episodes in the past month. And so these are just some of the themes that came up, and I'm going to go over them in detail. But one, type 2 diabetes diagnosis, kind of just enhance the perception of restriction, okay? And so that should already be, making you remember our previous slides about that binge eating restriction path. And then there's some barriers, economic barriers to binge eating treatment. Participants are engaging in eating to manage positive and negative emotions, and they have some coping strategies that they have been using to manage binge eating and type 2 diabetes. And so what we see, right, that perception of restriction, participants are working hard, right, to log their food, to monitor their glucose, and they feel like they have to restrict their carbs and sugar intake. And so what we have noticed that while we know that patients with type 2 diabetes have to have a different relationship with carbohydrates, it seems that when they feel like they have to restrict, that might plant a seed that could lead and, kind of create a pathway that could lead to some later binge eating behaviors. We also see that it's hard, right? Participants are experiencing multiple barriers that get in the way of them receiving and engaging in treatment to manage their binge eating and their type 2 diabetes. Financially, that was probably one of the largest barriers that we heard. And so you can imagine if you're already having financial challenges and getting treatment for your type 2 diabetes, then probably, you're really not going to be able to even think about getting treatment for your binge eating. And also just feeling the need for culturally relevant treatment and not feeling like their voices are, it's not really for them. And seeing that it's maybe catered more towards white clients. We also see a great deal of emotional eating, right? Participants are noting that they're eating to manage positive and negative emotions. And binge eating might be a result of a response to either one of those. But they are feeling that shame and guilt that we talked about earlier surrounding their eating decisions, right? Feeling like this is not what I'm supposed to be doing. And so patients to cope, they report using exercise, prayer. They really have found benefit from support groups of others who are also managing type 2 diabetes. And they would want therapy, but still feel stigma, right? They still feel like it's, that they don't feel confident and comfortable disclosing that and going to get the help that they need. And so this is what a patient said to us. I have anxiety and depression, and they go up and down. So as I go down, I'm going to eat those till those things go up. Yeah, it just helps me feel good temporarily. Then there's the guilt, and I'm back on track again. So this just maps on to exactly what we've heard and what we've seen in the research. Another patient said, I'm really scared to eat anything now. Yeah, because I know what's going to happen afterward and I lose control. My sugars will get all whacked out and stuff. And then all day I'm trying to get it under control. And when I get it under control, I'm just tired. It's like a job. And so in both of these quotes, what you hear is a weariness, right? Participants are they're thinking, their type 2 diabetes is a full-time job, right? They are focused. They're trying to manage their blood sugar. They're feeling anxiety. They're dealing with restriction. They're managing stress. And so these are things that are kind of centering and really impacting their reality and, making it challenging for them to navigate their eating behaviors. So now we're going to talk about what do we do, right? What is some guidance? What have we learned about how we can help these patients? I know some of you are going to be primary care physicians. Some of you might be mental health clinicians, just wanting to learn more. And so hopefully give everybody a little something that they can use in order to better help these patients navigate this. And so this was a study where they engaged with patients who had binge eating disorder and type 2 diabetes. And one thing that came out was that patients really wanted these things to be treated together, right? Knowing that their experience with binge eating wasn't a separate thing to their type 2 diabetes. And often it was siloed, and people are going over here and over there, but wanting it to be in one place. And so really wanting their primary care physician, right, to continue to engage in diabetes and binge eating disorder continuing education, to create a person-centered approach, and to have non-judgmental and emotional understanding. You can imagine how embarrassing it is for these patients to talk about their eating behaviors, right? To already, you see, they're probably looking at maybe the A1C or the glucose monitor and wondering about why some of these values might look the way they do. And so patients, again, they're feeling shame, right? And so for those who, might feel confident, it's comfortable to come, but we know some of our patients probably aren't coming, right? If they're experiencing the most severe binge eating, they might feel so much shame that might keep them from getting the help that they need. And so we see also that it's helpful to have a multidisciplinary treatment team, right? So we have everybody in the same place, those who, again, just part of the team, so that the care can be centered, as well as helping individuals with development of coping strategies, right? To manage some of the situations that might precede their binge eating episodes. and also help our patients to improve their self-care, right? To better maybe understand some of their thought patterns. I know often cognitive behavioral therapy has been cited to help participants understand that relationship between their thoughts, their behaviors, and their emotions, right? And to be able to help deal with some of the cognitions that might also precede a binge eating episode. And so this is a model that I think it might map on the best for primary care physicians. And so when we're going to go through it, right, to walk you all through just what kind of your intervention might be like, as you just see here, right? These are the 7 A's model. Okay, so we're going to first be aware, right, that people with diabetes may experience eating problems. We're going to ask about eating problems, which it seems simple, but it's not. There's a lot of stigma around weight. And I know sometimes I think providers feel like they are walking on eggshells around this issue. And so thinking about asking about eating behaviors might be even more challenging. So we're going to ask, though. We're going to ask them about eating problems. We're going to assess for eating problems. And then based on what we learn, we're going to either provide some guidance. We might make an assignment to another health professional. We might assist with developing a plan, and we might arrange for follow-up care. So we're thinking about, right, our first A, okay, being aware. One thing we might need to remember is there's certain risk factors that might be present with these patients. Again, that belief about food being good or bad. I know you all hear this a lot in your practices, right? These ideas that patients just hear. It may not be being said. Sometimes it is being said, but they're hearing and receiving the guidance as beliefs about foods being good or bad. And so that can create stress and a dichotomy that sets patients up to then, when they're, kind of be in a situation where they could have some more disordered eating behaviors. Patients might be preoccupied with their body size. Again, hearing guidance that if you're losing weight, this could help you improve your diabetes. That might put a lot of anxiety and pressure on patients to engage in like a weight loss effort, right? Patients might not be able to explain to you recent weight loss or gain. That can be an indicator, that something, disordered eating behavior might be present. And you're looking at what's going on with the diabetes self-management, right? How are they monitoring their glucose? Is it less frequent? Are they not monitoring their glucose and their outcomes? Looking at their A1C values, are they unexplained? Are they high? These might be things that might cause you to be aware that there may be some disordered eating behaviors that you need to learn more about. So now we're going to go to the ask part of the model. So when we want to assess, these are some ways, right? You can say it. I know sometimes, how do I say it, right? How do I make these? What do I say? And so these are some examples. You can use these exactly if it might be helpful for you. So option 1, you can ask some open-ended questions, right? Individuals with diabetes are often concerned about their weight or shape. How do you feel about their weight or shape? One thing I like about that question is that, makes it general first, normalizes that this is a concern that many individuals might have who are managing a diabetes diagnosis. So it already takes the shame out of it for the patient, because then they can say, oh, yeah, me too. I'm dealing with this too. Or another way, people sometimes feel that food and eating are a difficult part of managing diabetes. Do you find it hard to control what and how much you eat? Can you tell me a little bit more about it? How often does it occur? Again, you're making it general, normalizing the behavior, and then you are going into asking your question about their experiences with their eating behaviors, okay? And so if you're gonna go a little deeper, right, you wanna understand any changes in your eating patterns, anything in your life that might be reasons for your changes in eating patterns. And then you might directly just talk about, I've noticed that your A1C has been going up over the last several months, and you've mentioned that you have gained or lost weight. How do you feel about this? Can you share what you think may be affecting this? And so one thing I note in this, the patient, you've mentioned that you've gained or lost weight, right? I'm taking the patient's words. Often that can be an easier way to have the discussion versus we may be assuming, or putting our words on it, because it can maybe cause patients to maybe dismiss what we're saying, but to maybe start with what they've shared first and use that as a gateway. Then another way, so option one are the questions, okay? Option two is to just give them a questionnaire, and so this is the SCOFF. Remember we looked at the SCOFF a couple slides ago? Well, this is kind of one that's used for diabetes. And so you see, they can check it off very quickly. The questions that were similar. And so if they answer yes to one or more questions, further assessment is needed. So this is so short. It could be something that patients are doing in the waiting room before they come to see you. It's something that can easily be added on to a treatment protocol. And it is a very unobtrusive way to, I think, learn about some of these eating behaviors. And it might often be a way for you to start the conversation. And then you can maybe go back to some of the open-ended questions. So then you think about your part, right? You have to provide some guidance. And so you see acknowledging and eliciting feedback. So an example, from what you have told me, it sounds like you were having some concerns about your eating habits, your weight, your body image, insulin use. These concerns are not uncommon in people with diabetes. And so if you are okay with this, perhaps we could talk a bit more about what is going on and see what is needed to reduce your concerns. Another way to go about this is, okay, after listening to you, seeing your lab results, I wonder if you might be struggling with disordered eating or even an eating disorder. Now, even as I tell you all that, those words, again, due to stigma in our culture around who has an eating disorder, who has disordered eating, those words, depending on who you're talking to, if they don't have a lot of familiarity, this individual might identify as a non-majority racial ethnic minority, they may not be as comfortable with the word eating disorder, because this is not something that, again, we don't think anyone culturally, we still think this is a predominantly white issue. And so you just have to be mindful that you might have to think of it in a different way, right? To think about, do you struggle with maybe loss of control eating episodes? Do you struggle with, feeling like you don't have control, or just feeling like, you're eating, there might be just some concerns with your eating behaviors. You might need to think of different pathways and assess and think about the patient you're talking to, and then think about your language, because patients just might not understand eating disorder, right? I've seen that in my research. And then be able to invite them to share their thoughts. And so we also want to be able to, provide information about the eating problem that you identified, and to be able to describe what you've seen, right? So you might be able to talk to a patient about what it means to have a binge eating episode, and just describe it and see if that can resonate with their experience and how it's going to impact their diabetes management, right? What's the relationship? We also want to, see about the support. Here's the part that I think is the most challenging, is how we're going to get our patients the support that they need, right? And so if you're a PCP, right, it'd be great if there was a collaborative care team that you are working with, right? A therapist, a clinician that you are aware of who has expertise. You don't have to have expertise, but if you can think of someone who does, and create a relationship where you are referring to one another, who can help, just again, provide the patient just a few supporting elements to get them started. And then you really want to make sure that the patient is comfortable with this approach, right? Because we know our patients will be in our offices, and we have this whole plan, and then they don't follow through. And often our patients might have felt like, I'm not sure if this is a good fit for me. And so it might take some additional support, because it could be alarming to them to even hear, about the fact that this might be disordered eating behaviors. They may just need a little bit more support to understand what exactly you mean. So I thought it'd be helpful for us to go through a case study of a patient who is navigating this, and even just to see, just what some of your thoughts might be. And so this is Sarah. Sarah is a 59-year-old woman living alone, has been diagnosed with type 2 diabetes, has currently been managing with diet and exercise, and her PCP, she's going into a visit with her PCP. So as she goes to see Dr. Lydia, what she tells her is that A, she's been really trying hard to lose weight, but her efforts aren't paying off. She has gained about 12 pounds over the past few months, and she feels down about her weight and embarrassed about her body. Okay, so a couple different things might be coming into your mind, right? Even now, as I said those things as risk factors, remember, engaging in weight control efforts can be a risk factor for binge eating, feeling that shame and stigma about their body. Again, another risk factor, something that could perk your ears up. So you're like, okay, I'm hearing some of these concerns, trying hard to lose weight. So that might mean there's a lot of guidance out here, and a lot of it is not evidence-based, evidence-informed. And so patients could be engaging in some behaviors that might be more trendy, but may increase their risk of these disordered eating behaviors. So what are some things that we might consider, right? How could the PCP intervene in this situation? One, okay, as they're talking, the first thing, use some open-ended questions just to learn more about this, right? And even if you're not a PCP, you could begin, if you're maybe a diabetes educator or you're a clinician, you could begin to just assess. Often I remember when I was practicing, I would get anxious, when I would see a certain, symptoms, and I would first say, but the first step is for me to learn more about it, right? Learn more about how often this patient might be experiencing these concerns. And so what we see here in this as we go on is that after, the PCP has asked more questions, gone through some of the examples, she learns that this patient has struggled with her weight and is currently at the highest weight ever, eats little throughout the day, and then overeats most nights, and then overeats when she's lonely or bored. Okay. And so Lydia then gives the MSCOF to her. Okay. And so Sarah replies yes to 2 items. Do you make yourself sick because you feel uncomfortably full? And do you worry because you have lost control over how much you eat? And so as she reviews Sarah's responses, she sees that, she might be experiencing some eating concerns, and asks Sarah, again, wants to go back, reviews the results with her. And, and Sarah just acknowledges that she feels distressed about her overeating and her weight gain, and has a tendency to restrict her food intake, but then to overeat at the end of the day in response to negative emotions. And so as Lydia, she, offers her some guidance, she helps Sarah and reassures her, right? This can be fixed. Emotional eating can be addressed. And so she wants to help Sarah. One thing that might be a great beginning step is to help regular eating episodes. That's something as a clinician that we often would help our patients who are struggling with binge eating disorder, is to help them engage in a pattern of eating at least 3 meals a day and 2 snacks. So to eat regularly throughout the day to make sure that they are getting their body's nutrients, right? Getting what they're eating. And then also be able to provide her some tools to manage her emotions, because that emotional eating can be a big factor, and help patients be able to divide some, just some new things in their toolbox that they are able to pull out. And so then Lydia, when we think about assigning, right, she can help Sarah understand, okay, we have some people on our care team who might be great for you to meet with, and might make a referral to one of her care team members and to a dietitian, and then if she's satisfied, can ask Sarah again, how do you feel about these concerns, and what do you want to do next, and keep the patient centered in all of those things. Okay. So I just wanted to go through again, just an idea of what this might look like as we are navigating this with our patients. So when I think about the take-home message, right, we know that type 2 diabetes and eating disorders exist. And we see binge eating disorder, night eating syndrome. Those are, that's the disorder eating behavior that's the most prevalent. And so we need our providers, one, to be aware, to not be afraid to ask, to not create shame, to be able to help our patients understand what they're experiencing, and then to be able to refer them to professionals who can provide them additional support. And so when you think about, again, long-term solutions as you're balancing this diagnosis of eating, managing disordered eating and type 2 diabetes, it's so important for patients to have a reliable and a regular eating routine to help them deal with their diabetes-related shame and their stigma, really coming up with a process to help them regularly track their blood sugar levels, and then think about how can we provide some patient-centered education to help patients, I think, in addition to nutrition, but also kind of reconnect with their biological signals of hunger and fullness, and to be able to create healthy experiences around eating. So thank you all. And now I will open it up for questions.
Thank you so much, Dr. Good, and thank you all for listening in on today's session. We'll now go ahead and open up for question and answers. Please place your questions in the Q&A box. As a reminder, we will be sending slides from today's presentation out after the webinar has ended. And for any unanswered questions, we'll be sure to send those responses within 1 week from today. The first question reads, are these assessments normed and valid for clients under 18? I work mainly with youth and adolescents and find that many assessment tools have not been validated for these populations.
Yeah, the ones that I showed you were used for adult populations. And I think we are working on creating better assessments for individuals who are adolescents, but that has not really been, I think, a strength. And so I feel, because it makes it challenging, right, to be able to assess these behaviors. But yeah, the ones I did present are more often used in adult populations.
Thank you for that, Dr. Good. Do we have any additional questions at this time? Are there current eating disorder clinics in the US that work to help members with T2 or type 2?
I hesitate to answer that directly, like work together, because I am not sure of that, if there are those who work together. And so, but I can find out and make sure you all have that information.
Thank you so much, Dr. Good. The next question reads, and are these assessments validated across ethnic and racial groups, the assessments that were referred to during the webinar?
Yeah, I would say they have not been validated in every racial and ethnic group. And so that's probably one of the limitations. And so I would have to do a search of the scientific literature to see if they've been validated in, I'm not sure if there's a particular racial and ethnic group that you're seeing, but I think that is something that we've acknowledged has been one of the challenges in our eating disorder literature, is that these aren't validated in other racial and ethnic groups, but it might be a starting place and something that you can use that may give you an idea. I think one thing I know in my research, I'm often kind of striking that balance in maybe thinking about how the importance of the measure to be able to kind of assess some of the disordered eating behaviors. And then as I gain practice with it, maybe seeing about the ways that it could be made more culturally relevant in order to meet the needs of a population, but almost kind of taking I know my mom would always say, take the meat, leave the bones. And so I find ourselves in those situations sometimes, but we can still get a lot of important information to help us identify disordered eating in our clients.
Thank you. The next question asks, what about bulimia and type 2?
Yeah, that is something that we have seen as also, it's not as common as binge eating disorder, but we have also seen that is a concern. We don't have as much research. I think that's where I see the gaps. We don't have as much research on bulimia nervosa, but one thing I think is important to keep in mind is that both binge eating disorder and bulimia nervosa share the same commonality with the presence of binge eating episodes. And so the difference again would be the purging. And so some of those same things that might be risk factors for binge eating disorder are probably very similar risk factors for bulimia nervosa. And so I would say in that case, the clinician should just take the extra step. And some of those screening tools provide a question to understand if patients are engaging in purging behavior, because that adds an additional complication, I think, onto the treatment and would really warrant someone getting additional support and referral from a clinician who is skilled in these areas.
Thank you once again, Dr. Good. The next question asks, what is the incidence of insulin omission for the purposes of weight loss in T2DM?
Oh, I'll be honest, I'm not sure about that off the top of my head, but I can find out. We can pull that information from the literature. I'd have to just do a search and pull that information out.
Okay, thank you. The next question reads, what would you suggest we do to help reduce eating disorders, to help reduce diabetes later in life?
Oh, yeah, I think, well, one thing I think we've been learning, I'll tell you what I've been learning in my research lab. One thing I think we all, again, our frame of helping people engage in healthy relationships with food is very minimal, right? We have had a lot of guidance, right? We need to control our weights and a lot of different ways to do that, but we haven't had as much guidance about how do we engage in a healthy relationship with food, paying attention to our signals of hunger and satiety. I also recognize that a lot of our concerns with type 2 diabetes and disordered eating are related to social determinants of health, right? And so we have a system that has created an environment that does not give people equal opportunities to achieve the best health. And so that creates inequity, right? And so people are not having environments where they have maybe safe neighborhoods, adequate food, they're not having the economic resources to make the decisions that are best for them. And so when we're in those situations and whenever that's present, we're going to continue to see some of these disparities and some of this increased incidence continue to arise. Our food environment is also it's very challenging. It's very challenging. And so, and I think we're going to continue to see increased rates of type 2 diabetes. But I think if, again, what I'm seeing in my research, when we see patients and when they're helping and they're relearning how to work with their body instead of against it or ignoring it, we see that there's improvement in eating behaviors, improvement with weight management, improvement with glycemic control. And so we are just continuing to learn more about how do we continue to help patients kind of incorporate more of these behaviors into their life.
Thank you once again, Dr. Good. We had a statement that says, as people with type 1, they can abuse their insulin. And then the next question reads, how do you recommend talking about weight with patients with BED and type 2 diabetes? I work from a health at every size framework and usually just focus on the eating rather than the weight.
Yeah, so I would ask the patient what they want, because I think it's important for you to know if the patient is desiring to lose weight. And this is important for you to know for a couple of reasons, because ideally, I think if the patient has this in their mind and they're working on a weight loss effort, they are probably engaging. Again, it's a jungle out there. And so they are probably engaging with a lot of things that may or may not be evidence informed. I really honor and respect, I think, that I understand the intention of those who practice at a health at every size framework. And I can see the need, right, to do that because we know people have experienced challenges. I also, however, see that people still express desires to lose weight. And I think from a social work perspective, we often think about the self-determination of the client. And we have some recent science to show that engaging in evidence-based weight management does not lead to disordered eating, does not, can be helpful and supportive, and it might even help improve their, eating behaviors, especially if the patient has expressed a desire to lose weight. And so I would let that kind of lead my discussion, because if that patient has expressed that desire, you can probably pretty much bet they're going to someone else to talk about that. And you want to keep that, you want to be able to keep that door open so that you can help that patient make a decision that might be more helpful to them versus something that might lead them to engage in some diet, something that might, really harm them.
Thank you so much for that. Again, Dr. Good. I'll go ahead and take this last question, and the remaining unanswered questions, we'll get those responses to you within a week. The last question reads, for diabetes educators, do you have any pearls of wisdom on balancing guidance for weight loss and eating while avoiding putting patients in a position of feeling the need to engage in disordered eating behaviors?
I really appreciate that question, because I recognize, just the place that the diabetes educators are in. And so I don't know if I have any pearls of wisdom, but what I would offer from what we've heard from our patients is to, one, help patients understand this guidance to the shame, right? Somewhere they're hearing that there are good and bad foods, right? And I know one thing we often talk about is creating an environment where our patients are scientists and not judges, right? And so to help them take on an observation, and to examine, like, what is the impact of certain foods on our glucose, and then also helping them have skills to deal with situations where they may not have much control over their eating behaviors. What happens then? Because I think sometimes our patients just don't have the skills to navigate eating experiences that aren't controlled, or feel like they don't always have the tools, right? How do I make decisions in places where I may not be able to eat and, eat things I might be present and eating things I really, really like, and how do I navigate those in the context of my type 2 diabetes and create more conversations so patients can understand. I feel like there's still a lot of misunderstanding about what it means to have a type 2 diabetes diagnosis, still a lot of stigma and shame. And so I think to also help maybe patients get with each other, right? To find supportive networks of those who have been navigating this for a longer period of time. I know as a clinician, we have our opinion, but sometimes the words of someone who has been in these shoes might be more impactful and might be able to help them, examine and kind of understand what life looks like living with type 2 diabetes, and how we can't, think of things as good or bad, but we're continuing to learn how to care for our body with this diagnosis and help with the reframing of the language. And hopefully that will help not eliminate, but lessen some of the distress and the shame that patients are feeling, and normalizing, right? We're going to also normalize. So, yeah.
Thank you so much again for that, Dr. Good. I wanted to thank you all once again for joining today's webinar. Dr. Good, do you have any final words or comments that you'd like to share?
No, I'm just saying you all are, continue to do well. Thank you for caring well for our patients who are managing type 2 diabetes and disordered eating.
Thank you once again for your time today, Dr. Good, and thank you all once again for joining. As a reminder, be on the lookout for the slides and our evaluation at the end of the webinar. Thank you all for joining today.
Thank you.